of the Sri Lanka College of Internal Medicine, Dr. Ganaka Senaratne, to speak a few words.
Thank you, Dilusha. Good morning, all of you. Professor P. Ariyananda, Emeritus Professor of Medicine. Dr. Vasant Disanayaka, Professor Senaka Rajapaksa, Professor Tilak Veeratna, Professor Tilak Jayalat, and Dr. Harshatis Chandra, the distinguished past presidents of the college. You all are very welcome for this second session of Learning from Legends of Sri Lanka College of Internal Medicine. So, Learning from Legends has been established to bring expertise, experience, and the wisdom of our erudite legends of the field to the table, so that the present-day fraternity of medical practitioners could be benefited from that, and they could learn and shape up their careers and their practice. Today, we have the pleasure of having Prof P. Ariyananda with us for his talk on 12 roles of a medical teacher, how this model can benefit Sri Lankan physicians. Sir, you are very welcome in our home office of College of Internal Medicine, and for this wonderful platform of Learning from Legends. I'm truly grateful for Prof. Tilak Veeratna for nominating Prof. Ariyananda for his talk today, and Dilusha, Secretary, for passionately leading this project from the beginning. In a personal note, it's really truly a heart-touching occasion for me as well, because Sir is my own teacher, supervisor, trainer, and the mentor for all the years, and who has taught me skills, science, and attitudes to make me the human being whom I am today. So, ladies and gentlemen, I believe Sir's talk would immensely help the college to achieve its theme of the year, enhancing clinical excellence, capacity building, and human care. Thank you very much. Over to you, Dilusha.
Thank you, Ganaka. Next, may I invite Professor Tilak Veeraratne, past president of the Sri Lanka College of Internal Medicine, to introduce our esteemed speaker today.
Thank you, Dilusha. Good morning to all of you. I have the difficult task of introducing Professor Ariyananda because I know him for more than 4 decades from the days of my medical school, being an undergraduate. Professor Ariyananda is one of the founder academic members of the called medical faculty in 1978. And at the same medical faculty, later he became the chair professor and the dean. And when he retired, he was made Emeritus Professor of Medicine. And if I were to sum up all what his achievements in 1 or 2 sentences, I think the golden time we had with him was when he was the dean. And among his many achievements and services to the profession, I think I would value as the period that he spent as the dean, which was soon after the tsunami. And we were able to get hostel facilities for all the students in the Runa Medical Faculty. We are proud to say we are one faculty where all the students are given accommodation within the faculty premises because of his initiation, commitment, and deliberation. And not only that, he went outside the faculty and because of his dedication, very few may be aware that the current ETU, Emergency Treatment Unit, which is an outright grant from the Victorian government to the Sri Lankan government, was an initiative, and he went into every supervised item in the ETU. Those who worked with him must be aware how hard he worked to see the light of ETU, which is functioning as the best ETU emergency model care in Sri Lanka. Now, I have been fortunate to be his student during undergraduate days, his trainee, and he's my supervisor. And more than that, I think he has been a excellent role model as a medical teacher. I'm very glad that he's talking today of 12 roles of a medical teacher. I can't think of anyone else in this arena today who can really give such an authoritative talk on this topic. Without much ado, I would hand over to sir. Thank you very much for accepting my initial invitation over the phone and getting ready. And we are very much looking forward to listen to you over the next hour.
Thank you, sir. Now may I call upon Professor Arosha Disanayaka, President of the Sri Lankan College of Physicians, who has joined us virtually to say a few words.
Good morning to all of you. Thank you, College of Internal Medicine, President Dr. Ganaka Senaratna, my very dear friend, and the Council for inviting me also to say one or two words on Professor Ariyananda this morning. As many would know, I trained under Professor Ariyananda, and very simply, I am what I am today to a significant amount due to Professor Ariyananda. I was just thinking about Professor Ariyananda, and I just say in 3 sentences some of the things which I really admire about him. First thing is, Professor Ariyananda set very high standards for himself in the clinical setting, in the ward, in the academic and the clinical setting. He led us through setting very high standards for himself and setting very high standards for those who are junior to him. And because of that attitude, all of us work beyond what we would normally do because of his dedication and his setting very high standards for himself. The second thing is, whilst he maintained a very strict discipline and a very high standard, he would take a personal interest in all his colleagues, however junior they were. Now, Professor Ariyananda has carried my children. He knows my children by their names. And everything I achieved along the way as an academic and as a consultant to the point of becoming President CCP, Professor Ariyananda has been there at the ringside applauding me. He would take pride in the achievements of his juniors. That was really great and inspiring for me. And the third thing I really admire is that Professor Ariyananda never stops learning. However senior he is, what his age is, he will still keep acquiring new knowledge, new skills. Even after retirement, one day he told me, Arosha, I am thinking of learning to play the guitar. I mean, that was really inspiring because many of us consider ourselves too old to learn something new. But here we have our teacher acquiring new skills. So from all those 3 perspectives, I've learned a lot. I've got a lot from my life from Professor Ariyananda, and I'm very privileged to have been given this opportunity to speak about him, and even more privileged to listen to his words of wisdom. Thank you very much.
Thank you, sir. It is now my great honor to invite Emeritus Professor of Medicine, Professor P.L. Ariyananda, to deliver his lecture. Thank you.
Thank you, Dinusha. Dr. Ganaka Senaratna, President of College of Internal Medicine, past presidents, council members. Good morning to everyone. I'm really accepting this invitation with great humility. And it's an honor to deliver the second of this series of lectures called Learn from Legends. And also I want to thank all 3 speakers, Ganaka, Tilak, and Arosha, for their kind words. Thank you very much. So getting on to my talk, I chose this topic today because of 2 reasons. Firstly, we physicians are very busy looking after patients, but we have an important role to play in addition, that is to teach. So because of that, I thought I will impress on the need of that role on part of physicians who are really clinician teachers. So the second reason is actually In my next slide, which will come in a minute, there's some kind of delay. I know the internet is taking time. Okay, right. This gentleman seen in the picture, Professor Ronald Harden. He started life as an endocrinologist. He hails from Dundee, Scotland, and he has been the president of the World Federation of Medical Education and is currently the secretary of the Association of Medical Education of Europe and the editor-in-chief of Medical Teacher, which is a world-renowned medical education journal. So if you look at this slide, you see this article was published more than 20 years ago, and some of you may have read it, but there are many things that we can learn from this. And I have come to know Professor Harden because he had visited my last university, which is where I taught for 9 years, International Medical University of Malaysia, more than 100 times, because he set up, I call my whole university IMU, set up the curriculum there at the outset, because it started 25 years ago. And at that time, he was making so frequent visits. That's why he ended up making more than 100 visits. So he's a very familiar person to us, and he's a source of inspiration. And he has done a great lot to my last workplace. So moving on, now this picture, you may see some familiar faces. This is my last lot of trainees. At the time I retired from University of Ruhuna, Faculty of Medicine, Karapitia, after serving for 30 years in 2012. So President himself is here in this picture. He's seated on my left, but now today he's seated on my right. We train these people so that they become doctors who will be treating patients, not diseases. Just to quote the father of modern medicine, Sir William Osler, quote, it is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. He made this quotation more than 100 years ago. So it's the kind of product we want to achieve from our trainees, and I think almost all of them have done that. Now, I will just give you a glimpse of the outline of my talk. What is coming here, the penultimate bullet is the one that I'm going to talk for a longer period, right? So let's move on. My talk will take about 45 minutes. The word doctor is derived from the Latin verb docere, meaning to teach. When teaching, you'll be sharing knowledge, experience, and wisdom, as was mentioned earlier, with your students. And I feel most of us have the potential to teach more and teach better. So having that in mind, who are your students? Well, mostly doctors, trainees, starting from HOs, registrars, senior registrars, and colleagues, both physicians and surgeons and other specialty people. So during grand ward rounds, you meet them during multidisciplinary meetings and mortality morbidity conferences and other conferences. So that's where we do peer teaching. Then, of course, you have the responsibility of teaching your team members, nurses, pharmacists, physiotherapists, and so on. Of course, patients form an important lot of your students. Patients are your students because they learn, in addition to being a patient, as to how to manage their condition. You have to empower them as to how they should look after their condition. So are the carers and the family members. Now, I'm going to touch on certain basic principles of medical education before getting on to the meat of my talk, and those include learning domains, some aspects of curricula, Kolb's experiential learning cycle, and competency framework. Beginning with Kolb's experiential learning cycle. David Kolb is now 82. He lives in USA. He's an educationist, and here is what he had to say. When we do something, we often feel we could have done it better. So we think about it. What went wrong? What went right? Right? What can be done to make it better? So he put it in a cycle called Kolb's experiential learning cycle. So you think about it after the initial concrete experience, you feel, and then or think, oh, I should have done it better. Next time I'll do better. So in other words, you become a master of it. Actually, this is not a cycle. This is the ascending spiral. As you go up, you become more and more better. So that's what he said, and that's what we doctors go through every day with hands-on experience. So this again, it shows it in a nutshell in a cartoon. You reflect maybe part of your work that you're done for the day. Did I speak to that patient well? Could I have spoken to the patient better next time? So that's what is called Kolb's cycle. Let's move on to competency framework. What you see in the slide are well-recognized competency frameworks in developed countries. And today, I'm going to talk more about Scottish doctors' competency framework, for which Prof Ronald Harden was very much instrumental for, right? So therefore, that's the connection. And what he said was that when you are a doctor, the doctor should do the right thing and do it right and do it the right way. So let's go through it again. Doctor should be having skills to do, right? And then you approach it in the correct way. There are many ways of doing things, but you try to pick the best way. And then do it very professionally at the doctor-patient interface, you know. So that is professionalism. So all these three should be enshrined in your day-to-day practice as a doctor. Every time thinking of Kolb's cycle, try to do better if you're not doing it well this time. Touching on domains of learning, there are three major domains of learning: psychomotor, cognitive, affective. Go through it again. Psychomotor means manual physical skills. Then cognitive means mental skills or knowledge. And affective means attitude, what you feel about it, right? So whatever you do will come under these domains. As shown in the Venn diagram, there is some kind of overlap. When you do something, there is a combination of all these domains often. Sometimes it can be just one. I'll give you an example. If you want to ask a patient what the telephone number is, you remember the telephone number. So that is cognitive domain only. But on the other hand, if you want to call this patient and give advice over the telephone, you have to use all three domains, including picking up the phone. So therefore, we need to think of these domains of learning when we are teaching, because very often we tend to focus more on the cognitive domain and leave aside the affective domain, which involves medical professionalism and ethics, which gets more neglected, and we go for knowledge, right? And to some extent on the skills. So make use of all three domains when you are teaching. Of course, the balance will depend on what you are teaching. Now we talk of the curriculum. Curriculum has three major areas. In this perspective, what you need to know, which is called the co-curriculum. What is important to know and do, and what is nice to know. So as teachers, we need to make sure that your student knows the co-curriculum. What is nice to know is also good to know, provided the student knows about the co-curriculum well. So we have to, as teachers, when we are teaching and when we are assessing, make sure that we touch on those the co-curriculum. Definitely, you have to make sure that student is competent on the co-curriculum, leaving aside the rest of the curriculum. Coming to the components of the curriculum, here this diagram shows the 6 ACGME. The ACGME core competencies. What is ACGME? Accreditation Council of General Medical Education, right? So this is the equivalent of Sri Lankan Medical Association in USA, right? Accreditation Council of Graduate Medical Education. So what they say is medical knowledge, system-based knowledge, practice, interpersonal and communication skills, practice-based learning and improvement, that is CME, patient care, and finally, professionalism, which encompasses the 5 areas. Everything has a bit of professionalism, or a lot of profession, depending on the situation. So we need to ensure that the co-curriculum addresses all these 6 areas. Well, to what extent is the next thing. Now, if you look at this picture, this shows what is called Miller's pyramid. Miller's pyramid, most of you may be familiar. It gives you the level of competence, right? So if you take a medical student in the first year, they should know, but they need not do. So coming to the third year, they should know how to do certain things like say venipuncture, right? But you don't expect them to do any surgery. But on the other hand, if it is a PGI training, postgraduate training, they are on the top of the pyramid. They have to ensure that they know how to do things because they have to master whatever they are doing. So you go up in the Miller's pyramid, your professional expertise increases. So the core competencies will have to be linked to the level of competencies. And depending on the competence you are talking about, we will, the level will be dictated. So therefore, some competencies like say drawing blood, undergraduates when they qualify at final, they should be able to do that. So they have to do. But on the other hand, they know about say appendicectomy, but they are not doing appendicectomies yet at the time of graduation. So there is a kind of a spread depending on the type of competency and the level you need. What you see here is from the Government Gazette Health Act, and this shows what you expect from a graduate, right? So SLMC has got legal clout to see that the medical schools in Sri Lanka and also medical schools overseas that are recognized to for the ERPM and to practice medicine in Sri Lanka have these competency spelled out in their programs. Of course, this is just the outline in the Gazette, but each medical school is expected to have in detail what they are expected to train their undergraduates with. Talking about curriculum, I have taken two more commonly used types of curricula, and one is traditional model. I'm a product of traditional curriculum. When I was a medical student in Peradeniya, we had to go through that. But I think things have changed since then. The other type, which is more popular, is competency-based education model. There are many definitions of the curriculum. Reading Krug's definition in 1957, curriculum consists of all the means of instruction used by the school to provide opportunities for students' learning experiences leading to desired outcome. So desired outcome is what should they be at the time they graduate? What sort of competencies will they have at the time they graduate? So coming to traditional curriculum, educational expertise, they just sit down and prepare the curriculum depending on what they think is good for a graduate to have, but to learn in the school. But on the other hand, the competency-based curriculum model is addressing what the health sector needs out of a graduate. What competencies do they need? And then they work backward to prepare their curriculum. And most of the postgraduate curricula are like the latter, that is competency-based education model. So now I will be talking about my 12 roles, and here are the 12 roles. The 12 roles are derived from 6 roles, and each role is divided into 2, right? So that's how 12 roles come. Moving on, this gives a different look. What is highlighted in yellow is what most of us as clinicians will be involved. What is highlighted in blue is what you do back in the medical school, right? So I will go into each of these in some detail. Now, question is whether you would be doing this role, all 12 roles. No, not necessarily. You can do one role or few roles. And often we do few roles. And of course, some roles are direct face-to-face with medical students or the learners, and others, of course, can be done remotely, right? And these numbers that are given, they are just for my convenience, so there is no numerical order, right? Let's start with number 1, and number 1 is information provider and clinician guide. You have to observe that role, and you teach within the field of expertise. Don't talk politics, right? So organize and convey major teaching points at level appropriate to the audience. So that is with reference to Miller's pyramid. Postgraduates are taught differently from undergraduates, but you can teach about the same topic to both categories of trainees, but you pitch at different levels. Take initiative to continuously update field of expertise. So you need to, as a specialist, update yourself, read on journals, which are now all available online, and read the landmark publications regularly as they come. So that should become as a habit, and I think our college will pursue that. Then, of course, select appropriate teaching methods based on teaching outcomes, right? So if you have to teach about, shall we say, arterial blood gases, it will be a discussion, right? Or a tutorial. But on the other hand, if you want to show students how to palpate the abdomen and how to look for a spleen, you have to do it as a bedside lesson. Of course, you need to engage the learner and also invite the learners to ask questions and finally summarize what you have done. But in our culture, the learners are very much subdued. They rarely ask questions. That is something that you need to be mindful, but you have to overcome. You need to stimulate them and get them to ask questions. So in this role, you should engage with patients and their families in developing plans that reflect the patient's healthcare needs and goals. So therefore, you should facilitate discussions with patients and their families in a way that is respectful, non-judgmental, and culturally safe. Remember, culturally safe. Assist patients and their families to identify, access, and make use of information and communication technologies to support their care and manage their health. So some of your patients and patient relatives may be competent in IT, so they may be able to use certain apps for their healthcare. Use communication skills and strategies that help students and their families make informed decisions regarding their health. So you need to tell them, have patients meeting rather than be sort of telling or instructing them. You have to give them reasons, right? In the developed countries, it's the paradigm is a provider and client. Here, it's a doctor-patient. So we seem to have a fairly big gap between ourselves and patients, but it is good to encourage patients to ask questions and explain. One thing you've got to remember is the retention rate after 24 hours varies. So this is a sum up of a study and in US, and it shows that certain ways of teaching is more effective than other ways. So when it comes to, say, transferring information as an information provider, you can use the correct techniques, say, like if you want to even talk to a patient about a condition, you can talk then. So that means like a lecture kind of thing or discussion. Then give some material, reading material, and then give links. They are IT literate. So remember, you can use a combination. This will apply to teaching undergraduates, postgraduates, and your patients as well. Number 3 and 4, you remember you have to be a role model as a teacher and a physician. And how do you do that? Well, you have to showcase by showing enthusiasm in your field of experience and ensure you update knowledge and skills regularly. Don't delegate too much. You must show, you have to be in touch with your patient. You may be having good senior registrars, but make sure that you are in the scene. Practice holistic medicine, right? Like I said at the outset, and you should have very good clinical reasoning skills so that students can learn from them. Demonstrate sensitivity to each learner because different learners are different. Some are fast learners, some are slow learners, and so on. And postgraduates are better learners. Then, of course, you have to address the diversity and be sensitive to their diversity as learners, and also respect all the students as well as other people, including especially patients in the teaching community. And then always demonstrate accountability and responsibility, right? You need to take permission from the patient. If you are taking the patient for class, you have to go to the class in time. Don't keep students waiting, which is not correct. If you are getting late, you have to rearrange the class time. Then carrying on in the same thing, you have to demonstrate that you discern between right and the wrong academic behavior, right? You have to tell the students. Confront any wrongdoing among peers and students, right? So here, of course, peers, we don't talk about, but in developed countries, they do. And then, of course, you work as a team, you demonstrate unity, working through and sharing information, right? And so don't work in isolation. You have a team, you talk with them. And of course, you need to respond to your juniors or that is trainees requirements. Sometimes they'll ask the academic question, sometimes personal question like stress. You need to address those, right? So you should teach students, postgraduate trainees, and other healthcare professionals, and also the public. And in doing so, recognize the influence of role modeling and how it impacts formal, informal, and hidden curriculum of learners. I'm sorry, I have no time to say what the hidden curriculum is. That's another topic. You promote a safe teaching environment and ensure patients' safety is maintained when learners are around, especially learn to deliver, plan and deliver learning activities, provide feedback and enhance the learning and performance, assess and evaluate learners, teachers, and programs in an educationally appropriate manner. Now we assess our learners, our students by exams. We do for continuous assessment, right, or what is called formative assessment, which is very good, and you need to give them feedback. We really don't assess teachers, but in developed countries they do. In fact, in my last workplace, IMU, I had to end of year had to submit my annual appraisal, which had to include how much I have done in this 12 teaching roles. Otherwise, I wouldn't have got my increment or even the bonus, right? So that is part of it. But of course, the other things also the employee evaluates. So this kind of system may not be still operating because my former university was a private university. So private universities, they push on performance of their employees very much. Otherwise, and their employment is given, say, 1 year at a time or 2 years at a time. So coming back now, evaluation of programs, UGC is doing periodical evaluation every 5 years or so. They evaluate the medical teaching program, and I'm glad to say that when I was the dean, we were the top-ranked medical school in Sri Lanka when UGC came to evaluate medical faculty. So that just gives me the real happiness. 5 and 6, you need to be a facilitator and a mentor, and in doing so, you've got to facilitate and engage learners, supervise, mentor, and guide students. Create an open atmosphere that facilitates dialogue to issues contextual to the profession. Recognize learners in distress and provide appropriate resources within education structure to assist them. So this is also part of you as a trainer, right? See whether what's happening, because some of the, I know some doctors were addicted to medication. They did not turn up to the ward. Some were taking alcohol and so on. So you need to be on the lookout, and you can break that vicious circle they can go through by timely intervention as a mentor. This is another snippet from Government Gazette of Sri Lanka from the Health Act, where the government wants us to assess our undergraduates to see whether they are competent at the time of graduation. Of course, you know that there are very much detail in the curricula and assessment literature given in the medical school. So the government has given the clout to the SLMC to ensure that these things are done. Coming to 7 and 8, you will be a student assessor and a curriculum evaluator. In doing so, design and implement assessment program that delivers the learning outcome. You need to assess what you expect them to be and see whether they are competent. Not everything, they can have a lot of knowledge as students, but when you have to find what is in the core curriculum is known by students and they are competent to practice as doctors. Then you may have to do a role and where you create assessment material, and you have to be making a criteria-based assessment. You can use marking rubrics, right? Without being the impression kind of mark, right? Of course, giving feedback is a very important part of assessment, right? And that can be done well with continuous assessment or formative assessment, but to some extent with summative assessment, that is like second MBBS, third MBBS finals. Then, of course, students, you've got to tell their strengths and weaknesses, and the rest, of course, are very much of a detail for a person when you are doing curricular settings and appraisals. This is a snippet from PGIM website where the PGIM wants us to do multi-source feedback, which is a 360-degree feedback, asking from nurses and everybody else around in the ward how this doctor is and so on, which is a very good thing, which is done in developed countries. And I'm glad that PGIM is quite passionate about it, and it helps to make our trainees better. Giving feedback is a very important thing, it has to be given at the right time, and the student should expect. You can give it alone, one-to-one, or as a group, depending on what kind of feedback you give, right? And you should not be too critical. You have to be on the same side of the table, right? And give only a limited quantity, because they cannot, you got to give what they can chew or what they can bite. And not second-hand information. What the nurses said is what you saw, right? And confine it to behaviors that are remediable, right? Some student is stammering, don't say you are stammering, you got to correct that. You got to put up, right? And specific performance. You can't, don't say your examination technical abdomen is not correct. You didn't examine the spleen properly. You didn't turn the patient to the right side. Or that kind of thing is good, right? So you've got to be specific, right? And give it in simple language. So there are many things that you got to do. And this is in my last university, IMU, I'm taking a group discussion. You can see a student standing and going through a case scenario. And here we give feedback straight away, but if it's sensitive feedback, we have to call the student after the class and give it on a one-to-one basis. Roles 9 and 10. At times we have to be a curricular planner and a course organizer. Maybe most of you will not go through it. So you have to evaluate and identify gaps, propose improvement of the course. It can be something run by the PGIM. So as trainees, you physicians will be doing that. Then, of course, when you are doing it, you got to make sure that resources are available and constraints are addressed. If there are some things to get before setting it down in the program requirement, make sure that it's made available to the trainee. If the patients are not there, don't send PGIM trainees there. If the trainers are not there, don't send PGIM trainees there. So that's the kind of thing that you need to address. And training units have to be properly equipped in terms of availability of patients and material, and of course supervisors. And you need to have, for your own growth, when you have your program is evaluated, you need to show documents. So you need to have several documents for audit, accreditation, and certification. And fall in line with your professional bodies and get together and do curriculum planning and course organizing. So it can be diploma level, graduate level, or master's level, and so on. And final two roles, you may be playing a role as a guide producer, study guide producer, or resource material developer. So you should provide a study guide because it will alleviate a lot of anxiety. Otherwise, students are lost. They don't know what to do, right? And give a vocabulary of terms, mention the skills that are required. That's competency and competency level, and guide how to use the study guide, right? And also make sure that suitable resources are available, like say e-journals, electronic databases, textbooks, and so on. Here is a very important document. This is a 105-page document on MD, PGIM, right? General medicine. All of you must read this from cover to cover because you all are trainees, and the trainers too should read this. This is a very valuable document. It's available at the PGIM website, so you can download and keep it for you. Right. So it addresses competency-based curriculum, which is very good. So let's now see whether you can do the way you think. Factors influencing the role of the teacher. Well, it depends on the training program. If it's a medical student or group of students that you're teaching about cardiac auscultation, your role will be mainly information provider. Whereas you are training a senior registrar to do fiber optic bronchoscopy, you've got to have a one-to-one training session, and then during that time you will be providing information, you will be becoming a role model, and you will be assessing the trainee as to how well he's doing, because soon he will have to master it and do it properly, right? So that way, whatever you are, your role will depend on what you are doing, what kind of students you have in front of you. The seniority of students also matter. Third-year students are taught differently from final-year students. Third-year students are mainly taught about the basic physical science and so on, but when they come to the final year, they need to know about the diseases. And the house officers are told about the patient who has the disease, not the disease the patient has, like Sir William Oslerson, right? And also how you teach will depend on the curriculum, what type of it. So, I mean, problem-based curricula, you have more group discussions compared to traditional curricula where you have more lectures with a larger audience. And again, the culture. Sri Lankan students, medical students, postgraduates, they have gone through primary and secondary education in a very didactic manner. And even in the medical schools, some of them have gone through traditional curriculum. So it is hard to get them to talk and ask questions, engage in a discussion, compared to students in developed countries like USA, UK, Australia, where you see when elective students come, or when you go on, when you are gone for training, you see them, they are very sort of, they question, they challenge teachers if the teacher has said something wrong. So which, of course, in our culture will not be accepted. But actually what's happening in the West is good, because you just open up and you learn from each other. Sometimes, actually, I have learned from medical students also, certain things. So there's always room to learn from each other, and that kind of culture should be encouraged. So don't be get too disturbed if your registrar or senior registrar asks you a challenging question. This is what I read in the book or journal. And if you don't know, say, ask the train to tell me more about it. I'm happy to know about it. So those are certain things that you need to remember. Okay, now, IT help I need because I got stuck. Let me see. Okay, sorry. Finally, I managed to get to my slide. So this is the summary. These 12 roles are not guidelines, but they are a framework for potential areas of teaching. During a teaching session, we often play more than one role. We can change or switch from one role to the other within a teaching session. At the same time, also, we can have so many roles. Like I said in the example given for bronchoscopy training of a senior registrar. We can help students to grow in understanding, knowledge, self-awareness, moral development, and ability to communicate with others. Remember, as teachers, we are also managers in learning, curriculum designers, facilitators, counselors, evaluators, and disciplinarians. So we need not be competent in all 12 roles. We can play one or few roles that we are more competent in, where we have more aptitude. So few points to think about, just asking some questions. As a physician, do you think you have the potential to improve your teaching skills? I don't want answers. Do you pursue self-directed learning, SDL? Does the College of Internal Medicine support its members with regards to developing teaching skills? How is it done? So, what strengths do you have as a college to be a change agent? And as a college, what are the barriers you have for capacity building in teaching skills amongst members? And as a college, what strategies are in place to overcome such barriers? I don't want immediate answers, but these are things to think about as a college. At this stage, I want to tell that I gathered from the college president, Dr. Ganaka Seraratna, that they have done very good things in terms of continuous professional development. They are running a lot of training programs. I just got a copy of their journal, and within a short time, you're still in your infancy because you started in 2016. Thanks to all the presidents who have been there since the time of inception, you have come up in strides, and wish you, the college, all the best. And so that brings me, I think, to the end of my lecture. You've done a wonderful job as a college, and always has room for improvement. And these are my references. I'm giving these lecture slides to the college so you can quietly look at it. And to sum up, wind up, medicine must always be responsive to evolving societal needs, practice patterns, and scientific developments. Medical students objective project, Association of American Medical Colleges, which was published in 1991. It's available in the internet. The entire document is available. Happy to answer any questions there. Thank you very much.
Thank you, sir, for that illuminating lecture. I'm sure the audience has greatly benefited from your words of wisdom. In interest of time, I think it's difficult for us to entertain any questions. May I call upon Dr. Ganaka Seraratna now, our president, to present you with a plaque in appreciation of all the services you have rendered to the medical profession and the general public of Sri Lanka over the years. Thank you. It's now my duty to propose the vote of thanks for today's event. Firstly, thank you, Professor Ariyananda, for giving up your valuable time and delivering this lecture here today. We are truly honored by your presence. And our thanks to Professor Veera Ratna for nominating you for this lecture. And Professor Arusha Disanayake, so thank you very much for joining and providing a voice for this event as well. My thanks to Mr. Mawjood and Rodney and his team from SERL for sponsoring this event, and Chinta and Nishali, our office staff, for all their hard work to make this event run smoothly. And also to the audience for joining us today. And may I kindly invite you for the next session of Learning from Legends on the 1st of July. Thank you very much.